From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Hey, good afternoon, everybody. Welcome back to the Children's Mercy Bioethics Center webinar series. We're thrilled to have Trisha Prentice come all the way from Australia to talk to us about moral distress. I will introduce her in a little more detail in a minute, but first, just want to remind everybody that we have a year-long fellowship program here. It's open to philosophers, doctors, experienced child health professionals, people who want to spend a year really delving into some interesting and important bioethical issues. The deadline for applying for that is coming up soon, November 15th. So if you're interested in that, go to our website, childrensmercy.org, and look for the Bioethics Fellowship Program. We also have an online certificate program. Goes all year. You can keep your day job, don't have to come to Kansas City except at the beginning and the end. The deadline for applying to that is December 14th. Those of you who haven't been with us before for a webinar, here's how it works. Dr. Prentice will speak for about half an hour. Then we will open it up for questions from both the studio audience here in Kansas City as well as those of you online. For those of you online, if you have a question, you have to go to the little chat box in the lower right-hand corner of your screen and type in your question. We'll read it out. Or for those of you who are a little more digital media savvy, you can tweet your questions at hashtag CMBioethics, and we will read those out as well. Remind you that our next webinar is just in 5 days. On Monday, October 29th, Kyle Brothers is coming from the University of Louisville to talk about the ethics of embryo selection and germline genome editing. So that should be a fascinating webinar next Monday at noon. We are thrilled today, though, to have Trisha Prentice come all the way from the Royal Children's Hospital in Melbourne, Australia. Dr. Prentice is a neonatologist there. She has a master's in bioethics from Monash University, is completing a PhD at the University of Melbourne, and is going to talk to us today a little bit about moral distress in the era of shared decision-making. Thank you for coming.
Thanks very much, Dr. Lantos. It's a great pleasure to be here. I know that you've had many wonderful speakers in the past, including on this topic. So I hope today that I can provide a little bit of a different perspective. I have no conflicts of interest to disclose, but I'm thankful for some research funding that I've received to support the research that has provided the foundation for this discussion today. I just wanted to point out, given that I'm a relatively unknown person to many of you, that down the bottom left-hand side you'll see a picture of our unit, affectionately known as the Butterfly Unit, and the Royal Children's Hospital is there in the middle. On the right-hand side is the Royal Women's Hospital, where a lot of this research has been conducted. Now today I want to discuss how the concept of moral distress has evolved over the past 30 years, and in particular talk about the impact of shared decision-making on the dynamics of moral distress. I'm going to be using my research project called Modality, Studying for Moral Distress and Life Trajectories, to discuss in a bit more detail about how moral distress relates to perceptions about death and disability and best interest, as well as when healthcare providers disagree. I then hope to provide some potential responses to moral distress. Now, there have been many different definitions proposed for what moral distress means, but today I'm going to use a fairly classical definition to refer to the psychological distress that arises when a clinician feels constrained to provide care believed not to be in a patient's best interest due to factors outside of the clinician's control. Now, historically, moral distress very much arose within nursing literature, in which doctors were typically the top of the medical hierarchy, and they're often presented almost as a perpetrator, instigating aggressive, intensive care. Meanwhile, the bedside nurse is forced to carry out those orders, inflicting pain and suffering to a child or a patient that they believe is not in their best interest. So in this context, moral distress is often seen as an institutional failure that prevents a healthcare clinician from being able to advocate for what they believe is in the patient's best interest. It often implies that there's an abuse of power from the constraining person, and also often implies that the person who's feeling morally distressed is right in their judgment about the patient. So it often implies that there should be a change in management in order to achieve the best interests of the patient. Now, although literature on moral distress has evolved quite a lot since this point in time, I think it's still important to point this out because I think it still permeates some of our discussions today. Now, we know that moral distress is still most commonly caused due to the perception that care is overly burdensome and not in the patient's best interest. And it's particularly prevalent within our acute care settings. But today, moral distress no longer, or decisions about end-of-life decisions, are no longer made in isolation, but tend to occur within the context of a team and in the context of shared decision-making. Now, there are many different definitions about what shared decision-making means, and I'm not going to elaborate on that today, but rather just assume that it involves something along the lines of clinicians sharing appropriate treatment options, that the family communicates their own values and goals for the patient, and that together they agree on an option that best meets the patient's interests. Now, the difficulty with shared decision-making is that it often requires that we accept decisions that aren't necessarily perceived as best or ideal, but rather we acknowledge that as long as the patient's not being harmed, that there may be a zone of permissible treatments. And so we often refer to that as the zone of parental discretion, or I think in America you often more commonly refer to it as grey zone. The difficulty is that in reality, I think the zone of parental discretion often looks a lot more like this, where the zone of parental discretion feels incredibly wide. It can be really difficult to work out where that line between harming a patient or what's an impermissible treatment and what's permissible. Because, particularly in neonates, much of what we do doesn't have much evidence. In this world of medical uncertainty, there are many things that we're doing for the first time and we just simply don't know what the outcomes are going to be. Now, as a team, we may work really hard to try and communicate well, to come together as a team and try and create some consensus about what we all think is the best option. But there may still be some within the team who are left standing on the other side of the line, who still feel, because of their own personal beliefs and values, that what we're doing is still harming the patient. And so there are times when there'll be a team member who is still morally distressed, but their professional duty may require that they provide care viewed not to be in the patient's best interest. So in this context, parents can be perceived as constrainers, but let us be clear that this hasn't evolved from an abuse of power, and it doesn't even necessarily mean that moral distress reflects an institutional failing, although often there are many factors that do contribute, such as poor communication. But nonetheless, the experience of moral distress is still very real and still needs to be addressed. And we know that there's lots of literature about some of the negative impacts of moral distress, that it threatens moral integrity and it prevents a professional from acting in accordance with their professional duty. We know that it results in physical and emotional burnout, and many will leave their profession due to moral distress. The images on the right-hand side are obviously pictures from the Charlie Gard case, where nurses and clinicians received verbal and physical threats and even death threats, all for simply trying to do what they thought was in the patient's best interest. And ultimately, moral distress results in poor patient care. As part of our emotional response to moral distress, we often adopt avoidant behaviours. Families can often indicate which team members in the room believe that their child should not survive, even if that hasn't actually been articulate. And so it often results in a reduced rapport. I think most people are in agreement that we need interventions to try and reduce and manage moral distress. And you'll note that I specifically said reduce, because I think there is some degree of inevitability about moral distress, just because of the world of medical uncertainty that we live in. So we notice that within the literature, cases of moral distress often present a very unilateral perspective about the case before them. They often don't present the view of other stakeholders or other clinicians, and most of the time they don't actually provide an account of what's actually happening to the patient in question. At the same time, there's no truly longitudinal accounts that describe how moral distress changes over time. There are lots of conceptual accounts, but we don't have much empirical evidence about what actually happens to moral distress over time. So we wanted to start to ask some questions about
How often do disagreements around the management of preterm babies result in moral distress? How does moral distress and clinician perspectives change over time? Perhaps more importantly, though, we wanted to think about to what degree can moral distress be seen as an infallible marker that the patient's interests are being harmed. So in order to do this, we aim to follow 100 babies born less than 28 weeks. And we follow them from the time they were born to the time that they were discharged from tertiary level care at fairly regular time points. So more commonly in the first couple of weeks of life when there was a lot more acute changes in the care management. So on day 0, 1, 3, 5, 7, 10, 14, 21, 28, and fortnightly after, or weekly if they were still ventilated. And so we did this over an 18-month period. This took place at 2 neonatal intensive care units in Melbourne, Australia. So the Royal Women's Hospital is a tertiary level perinatal centre that specialises in the delivery of extremely preterm babies. And the Royal Children's Hospital just down the road is a quaternary surgical centre that only takes outborn patients but tends to manage babies with lots of complex medical and surgical conditions, including preterm babies with multiple complications. We prospectively enrolled 525 clinicians, including all the neonatologists at both centres, our medical trainees and 386 nurses. Now at those regular time points, we asked all of a neonatologist, a fellow, a resident and a nurse about the baby that they were caring for, whether that baby caused them moral distress, and if so, how much, and if they scored a moderate to severe amount of moral distress, we also asked them to provide a long or open-ended response as to why that baby caused them moral distress. We also asked them whether they thought the baby was going to live or die, and if they were going to live, what level of disability did they expect that baby would have, and whether they thought that survival was in the baby's best interest. We also wanted to know what level of care they thought the baby was receiving, what level of care they thought the baby should be receiving, and what they thought that the parents want. At the same time points, we also collected a lot of neonatal data about what interventions the babies were receiving in order to maintain their physiological stability. That is, what interventions were they dependent on? And we used those interventions in order to create a neonatal intervention score in order that we could have some way of tracking their clinical trajectory over time so that we could have a way of being able to compare one baby to the rest of the babies in the cohort. Now, we collected over 4,500 surveys over that 18-month period with about an 86% response rate. And in this neonatal cohort, moral distress was experienced on 15% of occasions. So just to be clear, there were other babies in the unit that would have also been causing moral distress. We haven't been able to measure the impact of that. This was purely restricted to the babies that were born preterm less than 28 weeks. 39% of our participants experienced moral distress, and of note, 91 out of the 99 babies included in the analysis generated at least one report of moral distress during their admission. Of note, neonatologists did experience moral distress, but they experienced it less frequently and of a lower intensity than both our nurses and our medical trainees. And we might talk a bit more about why that may be later. To give you a very quick snapshot about the babies, they were born at a mean gestation of 25 plus 6 weeks at 823 grams, and 13 of the babies died, including 4 on the ventilator, where there had actually been a recommendation to withdraw life-sustaining interventions, which the family had declined. Now, when we looked at the open-ended responses, there were 5 main themes that came up, but the one that was most common, that moral distress, was due to the clinical state of the baby in 83% of cases. That is, in 83% of cases, clinicians felt that either care was futile or that that the baby was likely to die, or that the outcomes were going to be so bad that it just wasn't worth it. 31% actually felt that the extreme prematurity of the baby was the reason for their distress. And so just to provide you with a couple of quotes, the fellow said, "His neurodevelopmental outcome is likely to be very poor, and he has made minimal gains from a feeding perspective post-term corrected. His parents' expectations are out of keeping with what can and should be provided to a baby with such a bad prognosis." A neonatologist said, "I believe that long-term outcomes does not warrant the financial and emotional waste or trauma that ensuring survival for this baby will bring." and again from a fellow, and I've written these directly as they were written by the clinician, so forgive any grammatical errors. But the moral distress was due to the difference between parents' wishes and parents' impression, and ideas of outcome of the baby and the actual best interest of the baby, and multiple underlying comorbidities. It's difficult to establish a plan for redirection of care because the parents always escalate their wishes of direction of care, again after de-escalation. So you can hear some of the experiences, the concern about the well-being of the baby, but at the same time there was often some concern that there was some constraint from the family, often due to a perception that the family couldn't understand or comprehend what the long-term outcomes would be. So far we've said that moral distress often results from the perception that we're doing too much, that we're providing overly burdensome care. Yet, when we did some regression analysis looking at our neonatal intervention scores, moral distress is very poorly correlated to illness severity. And that's partly a reflection of the great variability we see within our cohort. So particularly, for example, in our babies born less than 24 weeks, some of those babies were actually pretty well and had a pretty stable trajectory, but there were some background perceptions that because they were 23 weeks, that it wasn't in their best interest. Death, which we defined as a less than 25% likelihood of survival, was predicted in 36% of babies. Yet 36% of those babies actually died, so 13 babies. Unfortunately, we're unable to report our neurodevelopmental outcomes at this point in time, as we're yet to receive that data. But 74% of patients also had a report that survival was not in their best interest. And so while I've just provided you a small snapshot of the data, it appeared that moral distress was a poor marker that the predicted outcome would actually occur. So why I've said some of the reasons why people have been morally distressed, how much does it actually happen? So again, we looked at what clinicians thought patients were receiving in terms of the level of care, what they preferred would be the level of care, and what parents wanted as the preferred level of care. And there was a belief that parents wanted too much, that is, overly burdensome care, in 5% of survey responses. And of those responses, 71% resulted in moral distress. Interestingly, and that actually accounted for 24% of the moral distress that was experienced throughout the unit over that period of time. In comparison, the idea that parents wanted too little, that is that they wanted redirection of care where clinicians felt that that was inappropriate. So for example, in a baby that was 26 weeks, that resulted in very little moral distress of both low frequency and low intensity. It's important to point out that in 34% of cases, clinicians didn't actually know what parents wanted. So it was often a bit of a default plan. If they'd been admitted to the neonatal intensive care unit, they were having a pretty stable path. We just went to the default option of treating, although that number was reduced to 17% in neonatologists. What about the dynamics between the clinicians? So in general, clinicians agreed on what level of care that the patients were receiving at that point in time. So this is compared to with what the neonatologist or physician thought, and they agreed in 93% of cases. Most of the time, there were just subtle differences, such as the neonatologist felt that there were some limitations of care put in place, but these weren't recognised by either the junior medical trainees or by the nursing staff. So there's still clearly some room for improved communication about what are the goals of care for our patients. When it came to disagreements, our nurses and our medical trainees were more likely to want palliative care for the patient. If we frame things in terms of a classic moral distress situation, where a neonatologist preferred full intensive care, other clinicians wanted a limitation in intensive care in 7% of occasions, or withdrawal of life-sustaining interventions in 2% of occasions. So they're relatively infrequent events, but they did, when they occurred, cause a relatively high amount of moral distress. So in 76% of occasions, moral distress resulted. Now, if we looked at the agreement between the clinicians and the families, neonatologists were more likely to agree with families in 95% of the time, compared to nurses 88% of the time. And again, to frame it in the context of moral distress, Where nurses preferred comfort care or palliative care, withdrawal of life-sustaining interventions, but believed that the family wanted intensive care, neonatologists tended to align with the family in 74% of occasions, even though 16% of the time they believed that it wasn't in the patient's best interest. So overall, neonatologists appeared more accepting of the parental wishes than the other provider groups, despite still some evidence of constrained practice that they still didn't think it was in the patient's best interest. And it's possible that this may be just one of the factors that contributes to the neonatologist's moral distress. Of course, there are other reasons. So you can see some of the tensions that build up in our neonatal intensive care units. And it's understandable that when there's so much pressure and tension, that there can be a lot of pressure, particularly on the perceived constrainants, to try and resolve that moral distress. And we've referred to this as moral transference, that in these situations of moral distress, there's often a situation arises that when someone wants to get rid of their moral distress, that they may try to enforce their beliefs or judgments onto another person in order to absolve their moral responsibility and to reduce their own distress. So it may be, for example, that a nurse puts pressure on the neonatologist, who may then subsequently put pressure on the family in a paternalistic fashion to redirect care. Except in this case, we now have an abuse of power. And it sometimes presents where, although you may be raising up the voice of one person who's initially feeling distressed, it's at the cost of someone else, including the family for whom we have a duty of care. So to provide an example of this, a neonatologist said, "The study has not helped staff cope with accepting parents' decisions. The staff are getting more distressed because they have a name to put to it without thinking that this is a family-centred care unit. And the needs, thoughts and desires of the family come first, not the thoughts of staff as to what they think is right." So to provide some context for this quote, we had actually done a follow-up study to modality, asking clinicians what their experience of being involved in research on moral distress was like, because we knew that doing it over an 18-month period, that in some ways the process of asking people whether they had moral distress may have an impact on the dynamics within the unit. And so overall, the moral distress in the units didn't change. Nurses in particular felt validated, they felt heard, they felt that there was an increase in communication, particularly around end-of-life care. But there was also the perception, particularly from the neonatologist, that the level of moral distress within the unit had increased. So we need to be aware of just how the interactions play out within the unit. Now, I think there's often the feeling that in the current day and time, in the shared decision-making era, that parents have all the weight of responsibility in decision-making. But we can flip it around and think about that for families, it can actually be very difficult to fight back against the medical authority when it comes to decision-making. So at times it can feel like we're a bit checkmated, that we're trying to manage our own moral distress while managing the distress of others around us, while managing the distress of the families, and at the same time trying to keep the patient or the baby at the centre of everything that we do. So how should we respond as an individual and as an institution? And I think both of these things need to go hand in hand. We can't do one without doing the other. I think as a starting point, we need to assume that all have the interests of the baby at the centre, because I think that very much changes the conversation and helps us to share a common goal about what we're trying to achieve. Now, I should point out that when I talk about interventions here, there's very little empirical evidence about what are good interventions. Most studies that have been done have been very small. They tend to be in one provider group, and actually there hasn't been a lot of good evidence to show that there's been anything that works. But here are some of my thoughts. At an individual level, I think we need to be both increasing moral agency, but also be enhancing well-being or resilience. Now, resilience has got a bit of a bad rap in moral distress literature. We all seem to think that resilience for our children, for example, is a pretty good thing. It's a value that we want them to have. But when we talk about it in the context of moral distress, people are concerned that it means that you're implying that if someone doesn't have resilience, they've got a weak character, and so there's been a lot of effort to try and move away from that terminology of resilience. But I think we also need to acknowledge that as human beings, that the cliche things of whether we get enough exercise, whether we eat well, whether we sleep well, does impact on the way that we engage in conversations. It does impact on the way that we're able to have open conversations and hear other people's perspectives. Now, this image down below is adapted from one of our articles called The Use and Misuse of Moral Distress in Neonatology. And so it's meant to reflect the multiple, complex, messy components of moral distress. And moral resilience is a way of, trying to prevent that moral distress overflowing into negative impacts. Obviously, if you reduce some of the institutional factors that are contributing to moral distress, that's a win-win as well. But we do need some way of helping clinicians to be able to manage and adjust to the levels of moral distress in the unit. Again, we need to be thinking about our moral agency, not just in terms of empowering people to be able to voice their concerns, but also to be thinking about the way that our interactions with other people are contributing to the dynamics of moral distress within our institution. But I think we also need to be encouraging our clinicians to learn to live with moral subjectivity. That much of what we do has so much medical uncertainty, and so we need to be aware of our own values and our own judgments. That our opinions may be valid even if they are different. I think we can actually identify that moral distress can prompt constructive discussions and challenge potential management plans. Now, this is a little bit controversial. A lot of people don't like me saying that there can be some positive aspects to moral distress, but I think you can see that some babies or some patients get onto a bit of a conveyor belt of management. We tend to stick to a particular management plan, and it's only once distress is raised that people actually go, okay, let's stop, let's reflect, let's analyse what's going on here. And so it can be a trigger point to think again about what the goals of care at that point in time. And that can be a good thing. We need to appreciate that we're not particularly good at predicting the outcomes for our patients. I'm really thankful for the families who have pushed for treatment, and I've been pleasantly surprised at the outcomes. And we've learnt so much from those patients and families. And again, moral distress does not actually dictate that we need a change in clinical management. It may, but we shouldn't always assume that that's going to be the outcome. I think part of respecting the subjectivity is also reflecting ourselves on our own practices and belief. So I put some of these questions out there as just a way of thinking about it. So what is it about the situation that is causing me moral distress? Does everyone else think the way I do? If not, what are the arguments of those who think differently? Are my concerns arising from personal or professional values? How can I best care for and show compassion to this child or his or her family? And how can I voice my concerns in the most constructive manner? Now, at the same time, we also need to be addressing the institutional factors. We need to be prompting and encouraging respectful relationships in order that we can have transparent and open and constructive discussions. We need to ensure that there are processes in place to support our clinicians who are struggling with moral distress. We need to be providing opportunities for debriefing, both throughout the event and after the event. But we also need to be mindful that debriefing is not for everyone. For some people, the process of debriefing in the classical setting with lots of people around and sharing their distress actually adds to their vicarious trauma as well. Our ethics teams can be a wonderful resource, and I appreciate in America there are many of your institutions that have specific moral distress consultations. But the ethics team as a whole can also be really valuable, almost prophylactically, in helping people to think about their own perceptions and judgments, even before you get to the point of being morally distressed. I'm sure many of your institutions like ours also have other independent sources of support and counselling. So I guess my take-home messages are that moral distress is real and it has a large impact within the neonatal intensive care unit. But it does not always imply an abuse of power, even though power dynamics are at play, but can result from subjectivity in deciding a child's interests. Moral distress should encourage discussion and support, but it doesn't necessarily mandate a change in clinical management. Our clinical judgments aren't always correct, and so we need to be aware of claiming that care is futile and that parents' wishes are unreasonable. We need to be aware of the way that our own moral distress impacts on those around us and be careful of pushing our own beliefs and values onto others in order to resolve our own moral distress. And I think managing moral distress requires some reflective practice in order that we can learn to live with the moral subjectivity that is a part of our world with medical decision making. And we do still require research to address interventions to again reduce the negative impacts of moral distress. But I think we need to ensure that these interventional studies are actually addressing the unit as a whole and not just focusing on one provider group. Because again, as we saw, there can be interactions between the team members that we may not be capturing. I'd like to thank all of those who have been involved in this research along the way, including my supervisors. Many will be known to you, including Professor Lynn Gillam, Peter Davis, and of course, Annie Jambier. I'd love to hear your comments and questions and challenging thoughts.
Thank you, Trisha. That was amazing. I think everybody would agree this is pretty groundbreaking work, a different way of thinking about trying to understand the phenomenon of moral distress, quantifying it in different ways, and therefore perhaps coming up with new solutions. Let me remind the people online that if you have a question or comment, you can type it in that little chat box in the lower right-hand corner of your screen. We will read out those questions and comments for Dr. Prentice to answer, or you can tweet them to #CMBioethics, and we will read those out as well. I have a question to start with. I think your slide said 39% of participants experienced moral distress. This was of the 525 doctors, nurses. That means 61% experienced no moral distress. Did you look at whether there was a difference between the people who experienced moral distress and the people who didn't? And one other aspect of that, since moral distress was experienced in, I think it was 90% of cases, that means some people are having moral distress in many cases, and other people are never having it.
That's right. There were certainly some outliers of participants who were distressed all the time, and others who didn't experience much distress. We did collect a lot of demographic data about our clinicians. I think some of those elements are more about where clinicians worked within the intensive care unit. So those who are involved with the sickest patients all the time. So we have, for example, a pool of staff who look after our babies on jet ventilation, and they're a very small pool of staff. So they're constantly exposed to the sickest babies that some of these questions are constantly arriving. So those clinicians were much more likely to be placed in these situations where they were more likely to be dealing with a patient that there were questions about whether the baby should live or die, than perhaps someone who was looking at the baby when they were much more well and essentially a growing preterm baby that was expected and anticipated to get out of the neonatal intensive care unit relatively unscathed. We would need to kind of have small group discussions with some of those clinicians to dig down a little bit more about why some people are more prone to having moral distress than others. But there are definite kind of personal factors that seem to contribute. Which I think brings us back to the question of resilience. And I think it also asks the question as well about, is everyone suited to the neonatal intensive care environment? And that's a very controversial question. I know I'm about to dig a big hole, so I'm expecting lots of comments to fly in through tweets and things. But I think we're pretty lucky within the medical environment is that we get lots of exposure and you get graduated experience as you go through, that by the time you become a neonatologist, you've been exposed to these types of scenarios as you go along. And you hopefully have received lots of kind of support and feedback and time to reflect on whether your personality and your skill set is most suited to that environment. I feel particularly strongly for some of our nurses who, some of them enter our neonatal intensive care unit as their first kind of postgraduate position. And I don't think that they have the same exposure to different areas of nursing. So I think it can be very difficult for them because they haven't been given the opportunity to think about whether they're actually suited to that environment. And again, this isn't saying that some people are weak, and I'm not sure that when we measure numbers of what our retention rates are, whether that's necessarily a whole picture, because it may be actually a really positive thing that someone recognises that they're not suited to the neonatal intensive care environment and have gone on to find something that they find much more fulfilling and well suited.
So presumably you were able to look at whether moral distress was more common in people with less experience in the NICU versus more, nurses versus doctors?
That's right. So as I said, it was more common in less common in neonatologists than in nursing staff. In terms of how long they'd been in the unit, there was a bit of a, a normogram in a sense. So people who'd been in the unit for kind of 1 year, they often weren't that distressed. And I think that's because, as some of them would express to me as I was walking around with my iPad collecting these surveys, some of them didn't feel like they had the knowledge to know what their personal judgments were. They weren't quite as set in their beliefs. At the other end of the spectrum, those who had been there for 20 plus years, they were veterans. They'd seen it all. They might be hardened. They might have their various coping mechanisms. But reality is if they were still there, they'd probably worked out whether they could manage their distress along the way. And there would have been many who have left before that period of time. So most of the stress appeared to be in those who were kind of mid-career, who had had enough experience to see a bit, to collect, I guess, residue moral distress along the way, and to become a little bit more fixed in their ideas about what was reasonable or unreasonable treatment.
And if that's true, then you should be able to tell whether high levels of moral distress are associated with people leaving the unit. Is that something you're going to look at in a future analysis?
So certainly retention rates are something that need to be included in the analysis of any kind of interventional study. But again, rather than just saying, are you leaving the job, I think it needs to be raised why you're leaving the job as well. Yeah. As part of this study, coming back to the longitudinal amount and looking back at people's experience, we did actually have a drop in people saying, looking back at the past 5 years, 40% of our clinicians said that they had thought about leaving their job. Since doing this study, that number reduced to 7%. And again, there's probably been lots of different factors that have contributed to that reduction in people feeling like they want to leave the unit. I don't think it's just due to our study, but it shows a change in the ethical climate in which people are working in, and we need to work out why that's happened.
Again, if you have a question, you're watching online, type it into the little chat box. I think we have a couple of questions from the online audience.
Our first question is, whose moral distress should take priority? I'm assuming in cases where there may be multiple parties experiencing it and there may be some conflict in terms of what different people want to have happen. They put out 3 sets of individuals: the parents, the neonatologist, or the nurse or nurses. Do you have any advice to offer on resolving conflicts when moral distress is experienced by multiple parties and maybe in different directions?
It's really messy and it's really hard is the first thing that I'll say. And I don't know that I've got all the answers. And I'm not sure that there should be a kind of prioritization of any particular clinician or family's moral distress over the other. I think we do need to try and work as a team to try and, as best as we can, try and get a consensus, and hopefully there'll be as few people as possible being morally distressed as part of that process. But I think there'll always be some conflict between family's distress and the clinician distress. So I'm not sure they've got any real answer, but I think it requires ongoing hard work by the clinical care team to keep ensuring that they're both looking after each other, as well as acknowledging that the family is distressed and trying to balance those things out.
Quick follow-up on that one. You didn't measure or try to measure families' moral distress.
Yeah. So I would have really loved to have done that. This was difficult for me to get past our equivalent of an IRB as it was. They were incredibly concerned that even asking clinicians about their moral distress was going to have an impact on the families. And so it was certainly a step too far to ask families about their moral distress, but I would love to do studies on that. I'm hoping with time that we'll be able to convince our ethics committee or our IRB, that that's a worthwhile thing to do and an important step in how these families track later on down the track. And I was excited to hear at ASBH that there are some groups that are starting to be able to investigate that. So I look forward to hearing some of that data.
We have a question from Twitter. So the questioner is asking about this study presented was about babies born at less than 28 weeks. And they're wondering about babies with congenital abnormalities or medical diagnoses such as neurological conditions.
Yeah. So we needed a starting point, is the first thing to say. We fully acknowledge that there are many other babies in the unit that cause a lot of moral distress, including a lot of babies with congenital abnormalities. But in order to tease out the question about whether moral distress is an infallible marker, we needed a more homogeneous group of babies that we more or less knew what the outcomes would be. I think once you're getting into rare congenital anomalies, it's sometimes much harder to know what the outcomes are going to be, and there's a lot more uncertainty. So that's the reason why we restricted it to less than 28 weeks, in order that we could have a little bit more of a homogeneous population that we'd be able to compare and tease out some of these ideas. It would be wonderful to be able to then, as part of the extension, is looking in those cohorts of babies.
But if somebody wanted to study a different population, you'd share your surveys?
Most certainly. More than happy to collaborate. I'd love to hear
So
from
whoever
people.
wrote that comment on Twitter, go for it.
You'll
Study
notice
that.
my email
And,
address on the slide, so please contact me. I'd be very happy to collaborate and hear your thoughts.
Christina.
Yeah, thank you very much for the presentation. It's an impressive study. Like in 80 months, we were able to collect a huge amount of data. It's amazing. And I was very curious about the fact that clinicians say that parents want too much, and this is one of the main reasons why they experience more distress. What does this mean? Like, is this a feeling that clinicians have, or is something that actually they ask more practice, like parents actually ask for more interventions? And I really like your approach and your recommendation, like saying being more reflective and institutional, all of it, but don't you think that in this case communication would be a key, like improvement communication would help to address this reason of stress?
Thank you. So coming back to the first question, what does it mean that parents want too much? Again, we weren't able to ask parents what they actually thought. This is purely about the clinician's perspectives about what's going on. And so their expressions about parents wanting too much were that they thought that the parents were requesting intensive care that they felt was inappropriate for this baby, that the outcome for the baby was going to be so dismal that it wasn't the way to go for that baby. So these are all purely clinician perspectives. We don't actually know what the family's thoughts, and sometimes the family do actually have limits in their mind, and we just haven't teased that out. So again, it would be wonderful to be able to capture what would actually the family say in these situations. And your second question, sorry, just remind me.
Yeah, it was about like maybe a solution to that.
About communication.
Because I feel like sometimes doctors expect too much from themselves, and they give the image, doctors as well as institutions, or like clinicians as well as institutions, that they can solve any kind of problem. So I guess maybe sometimes parents have set higher expectations because of a lack of, not transparency, but maybe miscommunication. I don't know if this was your question.
Yeah, no, I think communication is a huge component that contributes to moral distress, and I think it's one of the things that needs to be addressed within that category of kind of institutional problems or areas that can be resolved, both communication between the team members but also with the families as well. We, at our institution, we do try ideally to have, for example, nursing staff involved in our discussions with families, but that's also very difficult as well, because we have an institution where babies are in a single room, and when the acuity is high, there's not a lot of freedom to kind of shift the nurse out in order that they can join us for those discussions. So it requires good communication with us, with the family, but then also feeding back to the bedside nurse about what's been discussed, the limits are, what are the next steps. but also trying to provide an avenue where they can also communicate their concerns in an appropriate environment as well. And sometimes standing right beside the patient or the family isn't the best environment to do that. So yes, communication is a very big factor. Communication did come up as one of our core themes of contributing to moral distress as well, and particularly people needing to know that there was a plan. They didn't always have a strong idea of what that plan had to be, but they needed to know that there were some limits in place. So I think that's another element, is us being very clear about what the goals of care are.
So just to be clear, it's not communication that led to moral distress, but lack of communication?
Lack of communication, thank you.
Go ahead, Charlotte.
Like what you said, the plan of care, did you see, I have two questions. Did you see a difference in the distress, perhaps for the nurses between night shift and day shift? Day shift because they're more exposed to rounds and care. And then my second one is, with all the participants, were they defining moral distress the same?
It's a wonderful question. So in terms of the first question about differences between night and day shift, I did try to collect surveys at different times. So I even went into the hospital at night times in order to try and get some of those nighttime perspectives. It's a little bit hard to break that down in the analysis, but my anecdotal impression is that yes, certainly there's always a change between shift, and as much as you try and communicate with the daytime and have debriefs during the day and try and get everyone on the same page, it can sometimes seem to unravel yet again once you get to that changeover at night. You're relying on the bedside nurse handing over to the bedside nurse about what's being communicated, and sometimes there can be a breakdown and a little bit of Chinese whispers as part of that process. So it is an ongoing issue. In regards to the other question, which I'm sorry, just remind me again.
The other question was, were all participants defining moral distress?
Yeah. So it's a very important question, and there's been a lot of attempts to work out how moral distress should be defined, whether we should broaden and use it as an umbrella term to kind of cover other types of distress that we experience in the unit, like the tragic circumstances or the moral dilemmas. We had actually done a study prior to doing Modality to try and understand what people thought when they were using the term moral distress. And we found the same thing, that most people recognize that moral distress has a component of constraint, but at the same time, they also kind of mixed in other definitions of things such as tragedy or other components that were distressing to them. And I think in reality, clinicians find it very hard to articulate out their different levels of distress, because sometimes multiple things are happening at the same time. There may be true moral distress, but it can also happen in the context of a very tragic circumstance, or there may be really worrying social circumstances that are contributing to their analysis of what's in the baby's best interests. Our way of trying to get around that was to, within every survey that they did, there was a definition provided, and between the two studies, they also tried to provide a lot of education to the clinicians about what the definition we were using in order to try and get as pure as we could. And looking at the data, I'm sure there are some cases where there were tragic circumstances and things influencing the scores, but it was the best that we could do was to try and define it for clinicians so that everyone was on the same page.
Again, if you're online, type your questions into the chat box or tweet them to #CMBioethics. Let's take a few more.
Next person says, thank you for a very interesting presentation. Were participants able to identify how they reduced any feeling of moral distress?
Sorry, how they
went about reducing their experience of moral distress? Strategies or...
Yeah, so we didn't ask clinicians to talk about how they reduced their strategies. It wasn't part of this study. However, in the follow-up study we did, people did request more interventions, particularly around communication. People did want more debriefing. So at one of the institutions, we actually introduced, I guess, similar to some of your ethics rounds here, but we introduced regular ethics meetings within our institution. That wasn't directly related to this study, but obviously impacts on some of the data that we may have been getting back. But no, we hadn't asked the question of what do they do to reduce their own moral distress. And I think in our institution there was still the expectation that a lot of it should relate to actually changing the management plan to the baby. So our first step was to try to tease out whether that's the case or not.
Next, I think we have a group watching from somewhere, and they have a group of nurses that want to know, was there evidence that the nursing staff challenged the neonatologist?
Interestingly, in our open-ended responses, challenges between team members was actually really silent in those responses, surprisingly so. As in, people tended to speak about being constrained by the family rather than being constrained by the neonatologist. There wasn't much of saying, we think the neonatologist needs to just man up and redirect the care. I suspect that people probably still feel that, and rather it was kind of being hidden or framed within the context of, we just think it's the wrong thing by the baby, as part of a more politically correct presentation. But it wasn't verbally expressed in those open-ended responses. Anecdotally, as a clinician, yes, we do have nurses come up to us and verbalize, quite frankly at times, that they think what we're doing is cruel or challenging, and it's a wonderful chance to start to explore and to remind us that there is distress in the unit. As I was speaking to a group earlier this morning, it's when that happens, I'm actually concerned that I've almost missed the boat in a sense, because it probably means that there's been lots of discussion that's taken place between nursing staff, for example, before they've actually had the confidence to come and speak to us at a physician level. So yes, there are challenges, and we open and welcome those challenges, because I think it's important as part of ensuring that we are doing the right thing by the patients, but also looking after our team.
One of the things we've found, and Angie, you may want to comment on this, is a nurse will come to a clinician and say, some of the nurses are experiencing moral distress. Not I am, but sort of giving a heads up, perhaps, of those same sorts of conversations that are taking place.
Yeah, and I think if one person's expressing it, it is most likely that more people are experiencing it as well. So I think if someone expresses to me that they're morally distressed, then I automatically think about unit-wide approaches rather than just focusing on that individual, because you know that it's going to be more widespread, and it does tend to be a little bit contagious, that once one person has voiced it, it changes the whole feel of the unit. So often when I was going around the neonatal intensive care unit, particularly at the institution where I wasn't a clinician, you could feel automatically as you were walking onto the ward the change in the vibe when things were going on. It was very easy to pick up on those tensions, even though I wasn't part of the treating care team there.
I was going to say, I think oftentimes it's one person being the spokesperson for many. There's been those discussions that are going on, especially if it's a night shift team that isn't there when there's usually discussions going on with the team. They will be wanting to, they'll become the spokesperson. And it's not maybe that they're not experiencing it, they just become that voice of many. And I think that sometimes is helping when we're talking about moral distress, that one of the interventions is giving voice. Instead of having to deal with there's a way to have those communication times when they can talk to each other. We want it to be respectful, but they need to have that voice or someone to help them bring that voice out.
Thank you.
Yeah, we still have several more questions online. Hopefully we can get to a few of them here. One person says, I was surprised by the percentage of clinicians who experienced moral distress due to not knowing parents' wishes. Can you elaborate more on what was going on there? Were parents not at the bedside or present to express their wishes, or did they not feel comfortable expressing wishes to medical staff? Do you have any anything you can add there?
Yeah, so again, most of the episodes where clinicians didn't know what the parents' wishes were and experienced moral distress tend to be more from the nursing staff who may not have had an opportunity to be in the meetings and discussing those openly with staff. We do have some families that are very absent from the neonatal unit. We certainly encourage family-centred care, but there will always be some families who, for various reasons, whether it's social reasons or other family needs, who are relatively absent, and sometimes they're absent because they're concerned about the discussions that are going to take place and are trying to avoid it as well. But sometimes I think clinicians didn't know what the family wanted, just because we had kind of set on a pathway of ongoing active treatments, which may have been appropriate for many of those babies, but most of those wouldn't have been associated with any moral distress. It was just that clinicians, when they were filling out their survey, didn't know what the parents' wishes were.
Did you find any cases where, when your survey that really what is on, many of them maybe weren't really expressing moral distress, but just stress of things that were going on in the unit or whatever, and they weren't able to really define how did this impact their moral agency or their moral integrity? Was it more, or did it come through? I just was curious.
Yeah, I mean, in the quantitative data, I can only rely on what answers people have given. In the open-ended responses, most people did express some element of constraint. You're right that there were a few in there that kind of looked at and thought they're probably feeling some other type of distress or the tragic circumstance of the mother who died on the table at delivery, rather than being true moral distress per se. So I think these numbers are always going to be conflated with some component of other types of distress, but it's the best we can do.
It's always still good to discuss those issues, whether they are moral distress or not.
That's right. Other types of distress within a unit still need to be addressed. It's just that the reason why we try to narrow down the definition of moral distress is because I think it probably does have specific or different interventions than other types of distress in the unit. So that's why we try to provide some conceptual clarity, even though we still need to address the other types of distress.
Next question asks, why do you think the nurses and fellows want more palliative care? Is it part of moral distress or response to that in some way?
Yeah, so I think they were more likely to feel that the parents were requesting unreasonable, aggressive, intensive care. So I think some of our nurses and our junior medical trainees were probably more of the view that we should be a little bit more paternalistic, whereas I think our neonatologists were more accepting of parental wishes. I think some of that may come from, again, our neonatologists, they tend to have a primary physician who continues to follow these patients along. So there's some continuity of care, and I think the neonatologists often have a bit more of a relationship with the families or an understanding of what their long-term goals and perspectives are that perhaps the nursing staff and the junior medical trainees may not always have.
Another?
Next question asks, when physicians and nurses share moral distress near the end of life when parents are resistant to withdrawing care, do you think it would be valuable if the physician inquired into the family's spiritual hopes and offered to provide prayer when appropriate?
So it's a little bit off the topic of moral distress per se, but yes, it's always very important as part of understanding parents' hopes and understandings about what their spiritual needs are as well. So we certainly do try to care for the whole patient and their whole family unit, including their spiritual aspects as well. And we have a number of supports throughout the hospital to try and do that. In Australia, there's probably not a lot of support for physicians having an active role in providing a prayer per se, but rather we rely on the support networks within the hospital of providing appropriate pastoral support, so a religious leader who matches with their affiliation to provide that more intense spiritual needs that perhaps we don't have the time to do so at that time.
I think we have time for one last question.
So much pressure. Thanks, Trisha. You spoke about respecting subjectivity and reflective practice as two sort of really important parts of this conversation. My sense is that it's a lot easier to teach people reflective practice than it is to get them to be comfortable with moral subjectivity. Because I was thinking, like, you know, someone could reflect and reflect and reflect and still never get to a point where they think, yeah, I'm okay with everyone having like different beliefs. So I was wondering if you could speak a little bit more about ways to sort of cultivate or promote moral tolerance and open-mindedness in clinical spaces.
Yeah, that's a really good question. And again, I'm not sure I have all the answers, but I think there is some value in reviewing some of the cases we have. As I said, sometimes as clinicians we can be really thankful for the patients who have challenged us and who have surprised us. And I think sometimes they can be used as case examples to remind us that we don't always get it right. And they can be used to help challenge people about their perceptions and their thoughts. So I think it's actively trying to engage in the complexity and the variety of patients that we have in order to try and translate that process of thinking and applying it to some of the patients that we see later on down the track. Does that answer your question?
Yeah, I mean,
Unfortunately, we need to stop. But let me remind everybody, just 5 days from now on Monday, Kyle Brothers is coming from Louisville to talk about embryo selection and germline genome editing. So that should be a fascinating webinar from 12 to 1 on Monday, October 29th. If people are interested in reading more of Trisha Prentice's work, she's been publishing like crazy in Journal of Bioethical Inquiry, Archives of Diseases in Childhood, Seminars in Fetal and Neonatal. Just look her up on PubMed. There's lots of papers, or email to that address, and I'm sure she'd be happy to send you some of these wonderful papers. Please join me in thanking Trisha Prentice for coming to Kansas City.
Thank you very much.